and you can see that you wrap many times around the either of the needle holders, and then you slide it down and go on to the short end and you catch. And that's the video that I will show you, that you will understand better. So you catch this, turn around and catch the short end that was in the needle holder, release it, and then go and catch on the other side, and then you have your spaghetti knot. So that's easier and simpler and faster than doing the 3, 2, and 1, and then you can go and take one more round at the end of the technique. Now comes the intracorporeal slip knot that you see many, from Taiwan is very common. As a half knot, it can become a half hitch. By applying tension on one strand, a plain knot can become an intracorporeal sliding knot by applying tension on one strand. So you can see it's in steps, schematic diagram. You can see that you're taking your first loop around, then you form a hitch, make it loose, don't keep it tight, so keep that, keep it loose over here, and then go back again. There it is. Well, catch the short end, and then you have got the loop that is formed. Push it in opposite directions, and then slide the knot out here. And as you slide it down, it just acts like a hangman's noose, and you can secure your knot. So this is a very quick way of doing it. It requires practice. You should not go in opposite directions. You will understand it more on the video. You see, I made my loop. It's loose, no problem. It's deliberately kept loose. And now I just slide it. Okay, so that's at the end of the game, and you can just cut the suture out. So this is a slip knot technique. This is to show what's actually going on. This is not my video, it's from a friend because he believes in doing slip knots. I don't do that for the Myanmar. I have a different technique, and therefore I had to borrow the video from him. One more, and then one more knot. Again, it's the slip knot. You can see the first knot is deliberately kept loose, and then you tighten it. So it's just like tightening the nose. Okay. Then we have what is known as the knot for free. Basically, what you do is when you are making your knot, you can see out here we have a loop that is made here. It is not freed out. So then when you are taking your next suture, you go through this loop with the needle holder and pull, and you get your knot. So it's called knot for free. This is a technique that was developed by Odara Sisi, who is not with us anymore, and it is her technique of knot for free. Right? And then you will see now the video to understand it better. welcome to. So you do your suturing the standard way, but you create a loop on the loose end. Pull. Okay, so that's the loop that is made, and you go through that loop and catch the short end and pull, and you've got your knot for free. When you are, this was all contralateral methods. This is Charles Cole's technique, and I prefer to do a lot of my suturing with the ipsilateral approach. And basically, what happens is that both your hands are on the same side as your body. I'm born right-handed, but at laparoscopy, my left hand is more dominant. So now I can use and suture with both hands. And since we stand on the left side of the patient, my left hand will carry the active needle roller through the left portal, and the post point, which is at the level of the umbilicus, is or about 10 centimeters above the first portal, is the one where my right hand needle roller will come through. And so normally when you suture from the pelvis to the head end. The patient's head is on this side, the legs are on this side, I am on the left side of the patient. I will suture from left to from pubic symphysis to key and I can also learn how to do right to left. Now you normally do it from left to right, but as time goes by, you learn how to use both your hands, and basically your suturing is done in the same way. So if you look at this one, this is your left knee roller, this is your right knee roller. You're taking your pass through the suture, and you made your loop, and then you made your knot. So then you come back again and do the double hitch again, second knot, third knot. So therefore, this is very easy when we are practicing on those bubble ones. We'll be able to do it. We may not be able to do it on the other one, but let's see. Now the future is with suture, as what I said almost 3 decades ago. Because it's very important to achieve hemostasis, secure pedicles, provide tissue support in surgical hemostasis, and for closure of the tissue, for example, vaginal closure and laparoscopic hysterectomy. Now, this is basically to tell you the suturing techniques for endoloops. Dr. Anand will cover all this. The classic microsurgical techniques were initially passed on from laparotomy to laparoscopy by Kurt Sem. There's also something known as the cinch knot, which I spoke about. What are the applications of the suturing techniques? When you're doing adhesiolysis, you may have peeling, so you may not be able to achieve hemostasis with a bipolar or electrical energy. Therefore, you would want to suture. Myectomy requires suturing. When you're doing pubal surgery for cuff salpingostomy, end-to-end anastomosis, salpingotomy for ectopic pregnancy, or salpingectomy, the technique has been developed with sutures to achieve all these results. If it's ovarian surgery, if the cyst defect is large, after doing a cystectomy, you need to close the defect, for which suturing is very important. Ovarectomy and hysterectomy can also be done using loop sutures. Hysterectomy requires suturing techniques for not only the closure of the vagina. Some people like to suture the uterine artery. I don't do that. I always prefer to use my bipolar. Appendicectomy requires the endoloop sutures to be applied, or intracorporeal extension techniques. And if the bladder, bowel, or ureter is injured, you must be able to suture it back on your own without having to require a general surgeon or a urologist who may not know how to do all that. And of course, the major area is the pelvic floor. You have a prolapse of the uterus, you've got suspension of the uterus to be done, or suspension for a wall prolapse, the birch repair for statutory incontinence, or Mamgeshikar repair for intracerebral. So there is a lot of scope in pelvic floor which requires suturing, and therefore you must be an expert at suturing. And with this, I end my presentation. Thank you.